Good evening and welcome back to JCN Live 2020. For those just joining us, thank you so much for giving up your precious time. It means the world. And for those who are coming back for the second session of the evening, you're a bunch of legends. Thank you very much. Before we start, just a big thank you to our partners for tonight's event, who are Urgo. Without your passion, without your commitment to independent education, these events simply could not and would not happen. So thank you so much from me and the entire team. Tonight's event is called The Reality of Shared and Supported Self-Care for Patients in Compression Bandaging. And our two amazing speakers tonight are Dr. Leanne Atkin and Joy Tickle. Good evening, both.
Hi.
Hi.
You both well?
Yeah,
good,
really
thank
good,
you.
Thank you. Yeah.
I'm tempted to say it's the first time you've done one of these events together for us. I'm slightly nervous that we've got both of you on the same screen. This could be a long chairman's gig for me. Ladies and gentlemen, as you can see, both our speakers are doing the event tonight from home. So if we have any problems with technology, bear with us and we'll sort it out as soon as possible. The event will be available on this Facebook page forever. The link for the certificate of attendance will be made available towards the end of tonight's event, and that's perfect for your revalidation portfolio. And also on jcn.co.uk, you can see the event, but also download the slides. I'm sure Leanne and Joy will agree with me, but the more involved you are, the better it will be for them and for the event in general. So make comments, ask relevant questions, and I promise you we will endeavour to answer as many as possible towards the end of tonight's event. So without further ado, it gives me great pleasure to introduce our first speaker tonight. Over to you, Leanne.
Hi, thanks to JCN and Urgo for this kind invite. So my name's Leanne Atkin. I'm a Vascular Nurse Consultant at Yorkshire NHS Trust. And me and Joy are here today to really share with you our experience of what it's been like through COVID with shared and supported self-care. So just to step back a little bit and just to think about where wound care was back in January of this year. Well, prior to COVID, I would say that wound care was already in crisis. We had phenomenal amounts of patients' volumes coming through practice nursing clinics, community nurses' visits, and this was costing the NHS £5.3 billion every year. Up to 25 to 50% of UK hospital beds was occupied with a patient with a wound. And actually we had huge issues with antimicrobial prescribing for wound care, with 16% of all antibiotics prescriptions being attributed to wound care. And if you think about, antibiotic resistance, I think the one thing that COVID has shown us is how terrible a virus or a disease is without a known therapeutic. People talk about that actually antimicrobial resistance is something that we're going to see within our lifetime. Never mind a virus, imagine that any type of infection, we had no known therapeutic. That scares me ever so slightly. So we have to consider about the whole of the burden of wound care. Many of you will have seen me present this slide before because it's one of my favourite pieces of data that we've got. I'm a leg ulcer specialist, really, and I really love management of venous leg ulcers. But we have huge issues across the UK. That healing data at 12 months for a simple venous leg ulcer is reported to be only 47% at 12 months. I can show you dozens of research papers where the control arm of the study, we can get healing rates of around 86% at 24 weeks. So 86% at 24 weeks is possible, but in reality, we're only achieving 47% at 12 months. Why is that? And the reason is that we've got huge unwarranted variation across the management of leg ulceration. We know we've got issues with the timing of assessment and poor assessment skills and diagnosis. We have the underuse of evidence-based therapies such as offloading, compression therapy, and venous intervention to cure venous hypertension and venous insufficiency. And we have an overuse of ineffective therapies. Things like reduced compression, light compression are all sub-therapeutic. And we call ourselves the National Health Service, but we are anything but. We have huge variations of commissioning, and it is a bit of a postcode lottery, especially when you think about specialist nursing services. And the reality is that you see images like this every day in your clinical practice. Problems with poor exudate control, poor bandaging technique, and even worse, the far picture on the right, the desperate need for compression. But there is a huge fear factor in terms of, are we allowed to compress it? And especially if the ABPI is 1.31. And to help to cure all of this and to solve this real inert problem that we've got within wound care, the National Wound Care Strategy has come together to formulate some new clinical recommendations. These are now launched, they're live on the National Wound Care Strategy page. And actually, the National Wound Care Strategy says that there is a huge opportunity to stamp out this unwarranted variation, as this will lead to improved healing rates, reduce patient suffering, and reduce time, both in terms of nursing time and physical cost. So we were making great progress with the National Wound Care Strategy. In the beginning of this year, we were fortunate enough to get a sequin specifically related to quality indicators for venous leg ulcer management. So everything was going great guns. And the sequin was actually launched in April of this year. So nationally, we were making great improvements, but actually, I'd just like to reflect a little bit on the reality of my personal service. I run 3 leg ulcer clinics a week between me and my team. We have the major clinic is on a Wednesday. It's a 3.5-hour session. There's only 2 registered nurses and 1 brilliant healthcare assistant in that clinic. In 2016, we had 18 patients on average. It went up to 22. And at the end of last year, we were seeing 36 patients within this 3.5-hour session. No additional resources, no additional staffing, no additional time. And I look back and I think, actually, it was killing us was just this increasing demand of wound care to the NHS. And I know I'm not alone with that. Many community nurses report that they are busier than ever. And this is because of the growing complexity and severity of the patients that you were treating. Combined with experienced district nurse numbers were falling, all of the transitional documents of the solution and the transition of the NHS Forward Plan all talked about keeping patients at home for longer and avoiding hospital admission. But that just actually increases the complexity of those patients being looked after by those nursing services. But was there any increased resource that came with that increasing complexity? So I think that's where we were at the beginning of the year. And then we heard that COVID was coming. I must say, in the first few weeks, it felt like we were preparing for an Armageddon. I think we were all running on adrenaline. We all threw a safety net around the most vulnerable of patients, and we did this the best we possibly could. We stopped our routine outpatient appointment, but actually this increased the number of home visits. Initially, the PPE felt like a dance in the pantomime. It was those goggles, it weren't those goggles were right after all. And we had huge problems in terms of the fear factor of our patients not wanting to see us or be cared for us because they saw us as the risk of bringing the virus into their home. And the COVID impact went further than just the individuals. We had problems with TVN services being redeployed. We had huge problems with the number of nurses' sickness, both because of shielding and also because of COVID. We became very reactive in terms of firefighting the issues that we've got. Unsurprisingly, the leg ulcer sequin had to be paused. And unfortunately, in the first few weeks, there were some huge issues, especially with patients being asked to self-care. I must say, me and Joy witnessed that this was used as a way of cleansing nursing caseloads. It was used as to abandon the most problematic patient by get somebody else to do the dressing. I look back at those and I think that was so wrong and rather shameful. But actually thinking about going forward, I have no real solutions. We have to think about how do we restart services, thinking of that second wave and the requirement of social distancing, still balancing the needs of the acute organisation. So it wasn't just me and Joy that were saying this. Urgo Medical were very forward thinking, and actually that they did a a questionnaire, a survey monkey. And this was an online, and we got 63 responses across the community nursing fronts. And let me just share some of the outputs that we had from this. So we asked, what was your current role? We had a lot of community nurses, practice nurses, tissue viability nurses, and a little smattering of podiatrists, which we like. And we asked them, do you routinely apply compression therapy to treat patients with venous leg ulcers? And overwhelmingly, the answer was yes. So just remember that for the next few slides and the results I'm going to present, actually, these are people that treat patients with venous disease on a regular basis and have good experience of how to do that. So we asked the audience, which system of compression were you using predominantly for patients prior to COVID? And a lot of patients were in full therapeutic bandaging, around 70%, with some other solutions in that. And then we asked, has the number of patients treated for leg ulcer reasons changed in terms of your daily caseload? And I think this is what we found across the NHS. 50% found no change, but 25% were seeing more patients and 25% were seeing less patients. This sort of brings me back to my reflection of how can we be a national health service when we have such variations simply in our caseload numbers because of the COVID impact. And then we asked, has COVID-19 affected your decision making when choosing an appropriate compression system? And it was really interesting that 45% of people responded that yes, the presence of COVID has influenced you and your compression system. And we dive deeper into this to ask really what specific had changed and the reasons why. So a lot of you identified that you were trying to actually visit your patients less, both in terms of your caseload and keeping your patients safe. Quite a few patients opted not to attend clinics. There was service restrictions, which were actually forcing you down a route that potentially wasn't one that was made with the patients at heart. And we had a change to try to encourage more people to be able to self-care. As you know, me and Joy are great believers in self-care. However, it can be done well, but at times it can be done very badly too. So we asked a further question. If you had changed your choice in the compression system since COVID-19, which system are you using more frequently? So we had a less amount of patients in compression bandaging and more patients in compression wrap system and leg ulcer kits, which could be appropriate. But then we asked again, do you have any concerns about the progression of leg ulcer patients and healing of those due to a reduction in your face-to-face contacts? And 55% of you reported, yes, you have concerns about the reduction and the impact that this is having to patients with leg ulceration and their ability to heal. And more worrying, we asked, are you aiming to return those patients previously treated with compression bandaging back to bandaging? And 45% of you said yes, you're planning to change it back. And that really worries us. It worries us because actually you're basing a treatment decision on the needs of the service and the needs of the NHS, not the needs of the patient. So we're using supported self-care as a way to reduce the burden on the NHS. But we have to question, is that best for the patient? Is this a second option? And is that patient really should be in compression bandaging as their first option? You'll know me and Joy because we wrote the leg ulcer algorithm. And, you know, we did that because we are great believers in supported self-care, because we do know evidence-based supports the use of compression hosiery kits. It's their front line in the National Wound Care Strategy. It's not just us saying this. And we know the beauty of this because it can empower patients. It does reduce the number of nursing visits, reducing the cost, and also it helps to get that brain connection of that patient between their underlying disease pathophysiology and their treatment. But to get self-care right, we need to make sure that the patient is enabled and supported. And there's lots of enablers out there. I'm also the chair of the Legs Matters campaign. I can't give a talk without giving a plug for our website. Please look at our website. There's lots of downloadable information there. Things like dressing logs, how to exercise, how to wash your hands. But we've got to ensure that we are enabling these patients with the simple things. Have they got enough dressing packs? Have they got enough dressings? Are they able to SOS and escalate those concerns and get a response in a timely manner from their clinician? We have to remember that self-care is not for all. There are a few issues I would say I would never entertain those discussions. If there is any safeguarding issues or vulnerability or capacity issues, it's not something that we should be going down. If you're questioning the hygiene of the home or the person in front of you, self-care is not something that we should be entertaining. We have other issues that we've got to understand. I believe that supported self-care is right for the smallest of wounds where the exudate is low and the limb is of a normal shape. But if you have problems with high volumes of exudate and misshapen legs, those patients need compression bandaging, not compression hosiery kits. We want to really bed in with you that we need to do some safety checks before we think about supported self-care. And really, these safety checks are really thinking about, is the leg suitable? Is the wound suitable? And is the patient suitable? And Joy's going to go into more detail about where we need to use risk assessment, where we need to consider patients' capacity, and also the importance of the correct dialogue. And the information such as the Urgo's 3D framework is really helpful, ensuring that we have that correct dialogue, because communication is key to all of this. Patient-centred care has to be because of the needs of the patient. The pathway that we wrote was based on the evidence, not on the requirements of the service. Yes, there were service benefits from that, but it's about using the correct therapies at the correct time for the correct wound on the correct leg. And bandaging has always been an important concept within that. We're not saying anything new. We've always had an equal balance of our pathway between the use of compression hosiery and the use of compression bandaging. This pathway is not a service solution. It's got service benefits, but this is the solution to enable wound healing. We have to make sure that this pathway is used correctly. Because if not, if we are putting more patients into compression hosiery kits when their wound on their leg is not suitable, this will actually increase the burden to the NHS, not decrease it. And more importantly, it will elongate your patient's time to healing, therefore increasing their individual suffering. We have to remember that individualised patient care is exactly that. It's about looking at the individual to make the right decision makings of treatment options for that patient. If we do that, we can get it right first time, but it's got to be of an individualised basis based on that individual, not based on the service needs. So as we approach the second wave, third wave, whoever knows how many waves we've got, we really need to think about how we use the enablers to reduce the burden on the NHS, but this cannot be at a detriment to a patient. So I'm going to hand over to Joy that's now I've set the scene in terms of the challenge to the NHS, the challenge to you as a clinician. And Joy is now going to dive even deeper into these areas to really talk to you from a practical point of view about what this means and how you can apply this in your everyday practice. Joy, over to you.
Thank you, Leanne. Can you hear me okay? Is everything, yeah? Brilliant. Yes, thanks, Leanne, and good evening, everybody. I'm going to be talking with you about those practice implications around that supported self-care this evening. And Leanne's already given us a great deal of information and evidence, and we know firsthand working in practice the pressures that all of you are under, not just before COVID, not just during COVID, during COVID and ongoing. We know there's going to be enormous pressures, and effective legal care now is essential now more than ever. And those patients should have that informed choice and be supported with the self-care. And I'm not saying anything that Leanne hasn't already said and that you don't already believe, but we must make sure that it's implemented in the correct way. So myself in practice, and before I actually, before treatment selection discussed with the patient, regarding possible self-care, it's really important we consider three crucial elements of their assessment. The assessment of the patient, is the patient suitable? Assessment of the limb, is the limb suitable? And assessment of the patient's wound, the ulcer and surrounding skin, is that suitable? And these are three crucial steps. If we ensure the above is undertaken, we'll get increased and correct diagnosis. That will mean safe and effective treatment selection from the outset, and help to promote that patient concordance, empower the patients to explore the possibility of that supported self-care. But as Leanne said, self-care is not for everybody. I'm very, as Leanne is, extremely passionate about supported self-care, but it's not for everybody. So let's start when I'm assessing a patient, or when you're assessing a patient, what that can look like in practice. We've already mentioned patients must have that clear understanding and mental capacity to make those decisions, but not just to make the decisions, to retain that information, to be able to put that information and that teaching into caring for their wounds. Certainly the vulnerable and patients with safeguarding concerns are not going to be suitable at this point for that self-care option. Of course, patients who may have issues with adherence to the treatments, I still see some patients who will remove their dressings and remove compression therapy. Now, we'll talk about reasons why later on, but certainly if I feel there's lots of issues with adherence to their treatments or compression, then, you know, I will open that discussion of whether or not they're suitable. Patients or family resistance, because we're not just talking about patients delivering their own wound care, we're talking about support from families or carers and patient choice. And you might, you know, importantly, you might make assumptions that your patient's really confident, seems really happy to implement self-care, but actually when you open up that dialogue with them, they're actually quite horrified or scared of actually implementing such care. And same with your colleagues, you know, implementing care for their family members may be very daunting. If there's issues, Leanne's mentioned, with self-hygiene or the home hygiene, where the patient's at a higher risk of potential risk of introducing infections or local infections, then that will be, you know, part of the assessment of whether they'll be suitable. And of course, capability. Some of our patients who have issues with dexterity, for example, rheumatoid arthritis in their hand or problems with sight, again, self-care may not be possible for those. So it's important, before I even look at the patient's limb or the patient's wound, that we talk with the patient. We know the patient, we know the patient's environment. Assessment of the limb then. So you can see on your screen that large disproportionate limb, significant edema present, those fragile skin, all of those factors, and with the evidence, and I know we keep mentioning the evidence that states that these patients should really be in the gold standard compression bandaging to restore the limb size, limb shape, to reduce the edema, to protect that skin. So when I'm assessing the patient's limb, those are the key factors I'll be looking at. Of course, high volumes of exudate. If there's copious amounts of edema and copious amounts of exudate, again, these patients' limbs are more complex. They need a clinician to support them and deliver care. And assessment of the wound itself. You can see on your screen that very large circumferential ulcer, tissue type, you know, the devitalized, sloughy tissue, the painful, fragile peri-wound skin, clinical signs of infection. These are all factors where I will then, with the patient, do my risk assessment, undertake that assessment to say whether or not the patient's wound is suitable for self-care at that point. And where there's areas of signs of infection or devitalized tissue, large areas of devitalized tissue, then I would reconsider self-care at that point. And also, let's not just think of a large wound, think of a small wound, and factors here that yes, small wounds tend to be suitable if we're just talking the wound for self-care. But what about that non-progressing small wound? sure, we should be reassessing and rethinking about whether self-care is the option if the wound is not progressing. Despite all the evidence, there's still factors contributing to non-concordance with compression therapy by patients. And I've spoke to many patients over 27 years of working in tissue viability and to lots of colleagues. And these are some of the main factors of that non-concordance with compression therapy. Certainly for me, the patients have a lack of understanding of the cause or are not consulted on the treatment options. And I still see that in practice, where I will explain to a patient how venous insufficiency, what venous insufficiency is, how compression works, how it encourages blood flow through the venous system back to the heart. And many of my patients who've had leg ulcers on and off for many years will say, nobody's explained that to me. Nobody's explained how the compression would help that. If they'd have explained that to me, I would have probably understood more and not taken it off. Other factors can be because of pain or leakage and skin problems. And yes, we have to manage those problems, and we have to help the patients to resolve their pain. But again, it's educating them that compression therapy actually will help to resolve those problems and reduce the pain level. And certainly practical things like difficult to apply, it limits footwear, it makes it difficult to bath and shower. And even today, I see patients who've had wounds for 6 months, 12 months, and still say, I'd love to have a shower. And, you know, as a clinicians, we've not offered them a simple system like a waterproof protector to enable them to shower. How would you feel if I told you not to shower for at least a week, let alone 2 months and 3 months? So again, it's looking at the impact on that patient's quality of life and how we can improve it. That will assist you with concordance. But there's also many reasons and various reasons that I still see in practice, and I know Leanne does because we've talked about it, where nurses and clinicians are not implementing compression bandage where it is necessary. You know, on those very large limbs, those distorted limbs, it's not being implemented. And a lot of those reasons are around time limitations, reduced staff numbers, even more so. Now, we think it's a quicker solution to implement self-care, but actually it's not. If it's not suitable for the patient, if the patient requires compression bandaging, you're going to, as Leanne said, elongate their suffering, elongate their poor quality of life. So, you know, we might say that some of our staff aren't trained, but it is, and I will, you know, say this, it's easy to be trained in applying compression bandaging. And if we're not, we're limiting the choices for our patients, and we're not having equitable care for our patients. If we get the incorrect choices, it is going to have consequences for everyone. But importantly for the patient, as we've said, those increased edema, delayed wound healing, increased pain, increased suffering, decreased, you know, lack of what I'm trying to say, confidence in compression therapy, so they won't want to try it again. And it's devastating for their patients. And frequently I've seen that. And I have put patients in some self-care options myself because I love the evidence, the venous forward study, but I've reverted back to compression bandages for those patients who find the bandaging more comfortable. And we must always ensure that these patients are reassessed and reviewed for those reasons. Consequences for you, you know, the patient's going to have protracted healing times, increased appointments, increased workload. But then the patients who are put in a self-care solution like this gentleman, a hosiery kit, who wasn't suitable, his limb was not suitable, he himself was, but not the limb. It was, you know, too much edema, too much distortion, and the knock-on effect was he asked the nurses to visit more frequently. It was painful. Unplanned visits mean you then have cancelled planned visits. So you've got extra work, reduced staff morale, increased frustration. And for your healthcare providers, it goes without saying, increased treatment costs, risk of complications, and obviously you could potentially lose services if you're not meeting key performance indicators. So as Leanne said, I'm not going to go into great detail. I want to share 2 patient stories, and time, you know, is a little bit limited, and we want to give you time for questions. But it is important to get the diagnosis accurate and timely. Evidence-based decisions are made with your patients. in dialogue with your patient and sharing that experience with your patient. And there's lots of tools out there. There's lots of simple guidance and tools. You can see this table that will assist you in selecting the correct compression therapy for your patient. So there's lots of good tools there. So to conclude, I want to talk to you about 2 patients and how I looked at the assessment of these patients for suitability for supported self-care. This lady is in her 70s. Let's start with the patient. She's got significant rheumatoid arthritis, problems with dexterity and mobility, and you can see that from the image of her hands in the picture. She has venous disease also. She's had a negative impact of living with this wound for 6 months, reducing her ability even more so because of the pain and discomfort, and she's becoming socially isolated, very anxious, and a great deal of pain, as I've said. That's made an impact on her life because she's normally very house proud, and at this point, due to the impact, she's finding it very difficult to care for her home. So there was a home environment issue there. She didn't want to accept how very proud. So we moved to the limb. So this lady had quite a lot of edema. Peri-roof skin was fragile and vulnerable, and indicating that there was a great deal of edema present. No real distortion or edema. The wound itself, moderate, agitate and small. And you might say, well, it's only a small wound. Maybe that could go into a self-care option, but it wasn't progressing. It was a 6-month history. With a real good dialogue with the patient, talking about the benefits and types of compression therapy, using the tables and the guides that helped me, the best decision, the evidence-based decision for this lady was compression bandaging. Because of the assessment of those 3 factors, she was not at this point suitable for that supported self-care. Within 8 weeks, she healed, and you can imagine the impact and the improvement on her quality of life. And finally, my final patient is a younger patient who had been self-caring, presented at clinic because of non-healing, patient who was married with children and works. Significant impact. She'd had this for 14 months. And can you imagine living with a wound if this was your mother, brother, sister, or yourself? Current infections affected her work, loss of income, didn't feel like a mom or a wife. Was self-caring. I understood that she wanted to self-care initially because it meant it could free up her time. She was taught how to care for her wound, but it was non-progressing, and she'd been going on for months with a non-progressing wound. Her limb from her assessment was very large, edematous. She got lipodermatome sclerosis, signs of venous disease, and the wound, as you can see, was large and not improving. High volumes. She was a candidate and required compression bandage therapy. Very reluctant at first to go into compression bandaging because of having to attend for clinic appointments, but with that really good, giving her the knowledge and the support, we set short goals. 2 weeks with a review, and within 2 weeks she was beginning to improve. Her pain had reduced, and at week 6 you can see the significant improvement. Now at week 6 we can then decide whether we choose and go down the pathway of the self-care option, but the dramatic impact to her quality of life. So in summary, self-care isn't for everybody, but it is for the right patients. And in times of crisis, we've innovated, we've adapted, and we've also learned. But not everybody is suitable for self-care. Quick solutions are not always the correct solution, and inclusive dialogue ensures that the patient's needs are fully considered and concordance with care is optimised. It's important to choose, as Leanne has said, the right compression at the right time for the right patient to achieve the best possible patient outcomes. And I'm going to hand over to Ed now for our Q&A session. Thank you.
Joy, thank you. Leanne, thank you. That was absolutely brilliant. Do you guys mind if I crack on with the questions? We've got
no, crack on.
So question 1, Joy, this is for you.
Ooh.
Are there any particular patients in your experience that you would say were not suitable for a self-care option?
I think really, Ed, hopefully I've answered it, and people can reiterate over that by going back through the presentation. But certainly patients where, they just don't want to, and we have to appreciate that. You know, I've got patients who very much can self-care with support, but their choice is no. You know, they don't want to be involved in managing their wounds. A lot of my patients won't even look at their wound when we're dressing it, let alone dressing the wounds themselves. So there's lots of factors that some of the patients aren't suitable for self-care, even if you as a clinician feel they may be. So I know we haven't got much time, but that's, you know, and the other factors, obviously, dexterity and ability.
I think sometimes we get numb to the wound. You know, that we anticipate and we expect patients to have the resilience. Just because we've become numb and we can see a wound and we don't mind the smell and we don't mind the exudate, you know, some people would be absolutely horrified of having to do that. And I think we have to take that into account, because just because it's everyday nature to us, you know, if my husband walks by and sees one of my pictures, he's still horrified. We have to take that into account. I think that we have to really try to differentiate. Self-care doesn't mean hosiery, and non-self-care doesn't mean bandaging. You know, we can have people that need our support that's still suitable for compression hosiery kits, but we have some patients actually that you can train the patient or the carer to put on their own compression bandaging. Unique cases, but potentially an option. I think it's all thinking about how much support does that individual need with the care of their everyday practice. And many patients still want the hand-holding in that. And I do believe that should be a requirement for us. It might not be us doing every single dressing, but it's certainly there at the end of the phone to be able to help to support that. Thank you,
both. Question 2 from Claire Erskine. Good evening, Claire. Leanne, this is for you. How effective is compression bandage when applied loosely to aid patient compliance?
It's not. Don't bother. Simple answer, don't bother. My favourite saying is one that I nicked from Alison Hopkins. Anything less than 40 milligrams of mercury is tickling the leg. You are wasting your time. It's like giving one paracetamol. Do not apply it. You are not helping your patient. You are elongating their suffering. We need to be talking about that patient to say right at the very onset, in terms of this is a potent anti-inflammatory devices compression. And yes, it might feel tight in the first few days, but over time it will start to reduce the congestion, the inflammation and the pain. We need to be talking about that correct dialogue. And the 3D framework from Urgo helps to support to make sure that we as the clinicians know what we're talking about and how to communicate that to our patients.
Joy?
And I think just to add to that is, Leanne, you're right. If we're not getting those sustained pressures, and that's the same when sometimes we talk about patients who may remove their hosiery kits or their wrap systems because it's a bit more comfortable, or loosen it off. We have to be sure that we are supporting and reassessing these patients, because that could be a reason why, again, that compression therapy is not working.
Brilliant, thank you both. I was prepared to put my hard hat on when I saw that question come through. Question 3 for Joy. Is there a checklist or recommendation that would make it easier for nurses to select appropriate compression?
Yeah, I mean, again, I think I showed you the table on the screen tonight. Again, that's been produced through Urgo's work around the 3D framework. So there's checklist tables. The pathway can help, you know, on selection of what type of compression. And I'm happy, and I know Leanne is happy at the end of this presentation to give out, you know, to give you guys some links and share that with you and expand on that answer a little bit more. But there's lots of tools that can support, and that table was just one real simple table that can help you when selecting. Yeah, so it doesn't just look at the patient, it looks at the limb and the wound, and helps you to make that selection. So,
and I would urge every clinician to download the National Wound Care Strategy Lower Limb Recommendations. The Urgo 3D framework isn't in conflict with that. It's an enabler. It goes more into depth and gives more practical solutions of how you can do that. So these two documents go hand in hand. The National Wound Care provides the overarching evidence of why we need to do and what we need to do. And actually the 3D framework helps the clinician of how am I going to do that in my everyday practice? How am I going to have those communications and those dialogues?
And I think Leanne's right. I like tools that I can have in my practice and use simply without having to, digest too much, because of time and limitations. So yeah, the two go hand in hand beautifully.
That leads us on nicely, actually, to our next question. It's similar, but I think more around consistency. So Leanne, for you, this is from Karen Simpson. Good evening, Karen. Is best practice and pathways the same across Britain or different for Wales, Ireland, Scotland and England? I know formularies are regional, but wondered if guidance was universal.
Okay, so evidence is universal because evidence is evidence-based. So yes, it's universal and you can apply that evidence to anywhere across the world, really, because that tells you the best evidence. The National Wound Care Strategy is commissioned by NHS England, but we want to have spread into all corners across the UK. So there's no reason you couldn't use this. Has it got any power in Wales and Scotland? No, the probably answer is no. But, the last documentation that we've really got from Scotland is the signed document for venous leg ulcers, which is outdated. Wales have done some great stuff locally, especially stuff in terms of really combating the requirement for a rigid ABPI. But I think that we need to sort of break down this, what is Welsh and what is English and what is evidence, best practice is best practice. And yes, just because the document might not say best practice Wales and it might just be best practice England, it doesn't mean it can't be applicable to your patient group. So like the barriers of silos within the NHS, I think having 4 different NHSs isn't helpful, personally.
Thank you. So based on the time and the amazing commitment our audience has given us, we're on to our last question. This is from Denise Wood, and probably for both of you, if that's okay. Thank you, Denise. If self-caring, do you still advise seeing them for regular reviews?
Completely and utterly yes. If not, it's called abandonment of your patient. The National Wound Care Strategy says that should be done on a 4-weekly basis as a minimum. And that touch point could be a video consultation, a telephone consultation, or a face-to-face. There is a requirement with the sequin from the National Wound Care Strategy and a good quality indicator that we take some measurements of a wound on a 4-weekly basis to make sure that we're on a wound healing trajectory. So yes, minimum 4 weeks. But if your patients have the ability to self-care and the limb is appropriate and the wound is appropriate, your patient still might require a touch point 3 times a week. If they are concerned of, am I doing this right, love? We have to hold their hand in the first few days to build up that resilience and that confidence. Self-care is great and is enabled by NHS England, but it's got to be from a patient's point of view. It cannot be from a service, this is better for us point of view.
And I totally agree with you, Leanne. And I think it isn't just about reviewing the wound and reassessing the wound and the limb. As Leanne said, it's having that open dialogue with the patient about the impact on their quality of life, how they're managing. And I think quality of life is still something we don't quite get right at improving all of the time or respecting, really. But I think it is about the reassessment of the treatment, but it's a reassessment of how the patient is managing, how they're coping. Because sometimes I've had patients who've stopped self-care for a short period of time, just when their confidence has been low, particularly if they've had an infection, they get scared and we resume a little bit more input for that patient. So we have to be flexible. But again, like you say, that it's giving them the confidence and the skills, and the carers as well. Let's not forget the carers in this instance, and giving them the right tools to know when and how to contact people if there's a problem. Brilliant, guys. Thank you.
And thank you for tonight. That was just such a brilliant event. And a quick one, actually, to you guys out there. And I say this every time. Your comments are so kind, and don't think they go unnoticed, not just by me and the team, but the speakers as well. Look back, and you don't have to get involved. You don't have to write these comments. You don't have to ask the questions, but boy, does it make it a better event. And actually, genuinely thank you for your kindness. Leanne, Joy, please have a look back if you get a second, because there's some lovely stuff being said. The certificate for attendance is available. The link is now on the screen. It's in the comment bar. So download that now. And for more education, more events like these, some with Leanne and some with Joy, go to our website at jcn.co.uk. So that concludes tonight's events. Please come back tomorrow and Wednesday. There's some amazing stuff going on, so we'd love you to come back. But if you don't, have a very Merry Christmas. A big thank you again, Leanne, Joy. You don't need to do these events for us. You do. You were brilliant. So thank you. To the team at Urgo, thank you for your support, for your hard work. Guys, visit their website. They do some amazing stuff across the UK, so get involved. To my friends at the JCN and Mole Digital, another great event. Looking forward to seeing you tomorrow. And most importantly, to you guys out there, to our delegates, thank you. You're amazing. Thank you for your hard work. Thank you for your support, and thank you for your loyalty. So guys, hope to see you tomorrow. Have a fantastic evening and a very Merry Christmas. Good night.
Good night.